Hi, everyone. I'm Stephanie Connon-Oldrieve. I'm the founder and director of Craig's Cause Pancreatic Cancer Society. We're based in Nova Scotia, Canada. And we're proud to be one of the founding members of the World Pancreatic Cancer Coalition. It grew from 3 organizations to over 100 patient advocacy organizations from around the world now. And this is a topic that's near and near to my heart. I'm very passionate. I really started learning about what pancreatic enzyme insufficiency and PERT is and the benefits of it about 4 years ago. In Craig's Cause Pancreatic Cancer Society has really been quite passionate about it ever since. So we're excited to be part of the Power of PERT discussion that's happening today and for you all to meet the guest speakers. And I'd like to thank all of you for joining us. One of the most important roles of the World Pancreatic Cancer Coalition plays is connecting all of us with each other, sharing information, best practices, and being able to collaborate. So today's webinar will be part of at least 2 webinars that's provided this year by the World Pancreatic Cancer Coalition members. Today, as I said, we're talking about specifically pancreatic enzyme insufficiency and PERT. Good nutritional care, we know, improves the outcomes of patients and the patient's quality of life. This means that we need to have a really firm understanding about what PEI is, or pancreatic enzyme insufficiency is, and not only how to treat it with pancreatic enzyme replacement therapy. So there's 2 ways if you have questions. So each of our speakers on the panel will be speaking for 10 minutes, and we're going to allow for 5 minutes of questions. So you can either type your question into the chat box, and after their 10-minute discussion, there'll be 5 minutes of questions. So make sure you type your questions in and we can come back to you. Or you can also put up your little Zoom hand, and that's found on the bottom of your screen under reactions. So you can just put your hand up and we will scan the screen and we'll call out your name. Please don't be shy. We don't want a quiet Zoom discussion. We want people really, jumping in and asking questions. It will be recorded, as I said earlier, and you can send this recording out to the individuals that you work with, patients, caregivers, and healthcare professionals. So if you've missed this session, you certainly will have the resource to follow up and learn. I'd like to take this opportunity to thank our sponsors, because without them, the World Pancreatic Cancer Coalition really wouldn't exist. So we have AstraZeneca, Ipsen, Merck, Novocure, and Novartis. We're so grateful for your commitment and support for the World Pancreatic Cancer Coalition. So I'd like to thank you. Today, our guests are, I'm very excited because I've worked with all of them. They're phenomenal. Dr. Enrique Dominguez Monaz is a professor of medicine and director at the Department of Gastroenterology and Hepatology at the University Hospital of Santiago de Compostela. Sorry, Dr. Monaz in Spain. Dr. Poppy Casvis. Poppy just became a doctor. Congratulations, Poppy. Is a clinical nutritionist and dietitian at McGill University Healthcare Center in Montreal, Canada. And Dr. Amanda Landers is a senior clinical lecturer with the Otago Medical School in Christchurch, New Zealand. She also leads the Aotearoa, Australian Pancreatic Enzyme Replacement Therapy Research Group, which strives towards best practices for those with pancreatic cancer in Australia. So I'd like to thank all of you, and we will get started. So Poppy is our first speaker. Dr. Poppy Casvis.
Hello, everyone. Lovely to see you. I don't know if I need to talk about my credentials, but as Stephanie mentioned, I work at the McGill University Health Center in a very specialized cancer rehabilitation program. And my research interests thus far have been pancreatic cancer and how diet and exercise interventions can improve health-related quality of life among these patients. So you can look for some of the research that I published on that topic. Next slide. So Stephanie already alluded to pancreatic pancreatic exocrine or enzyme insufficiency, or PEI for simplicity's sake. It really happens very commonly in the cancer of the pancreas because of the tumor location. Either ducts are blocked or the pancreas is damaged in a way that digestive enzymes are not made. And these digestive enzymes are required in order to break down foods into absorbable components. So without these enzymes, we could actually really quickly become malnourished, and it makes it very difficult to digest food. And the results of this actually has a negative effect on quality of life. PEI is very common in patients with pancreatic cancer. And this is in both patients who are undergoing surgery or who have palliative end stage or very aggressive cancers and are receiving palliative treatments. And maybe next slide, Craig. We'll go over some of the statistics that are out there. So PEI is, as I said, very common in those who cannot have surgery. So those undergoing palliative treatments. And it's 3.4 times more common in tumors that are located in the pancreatic head versus the pancreatic tail. And that's really because the majority of the enzymes are produced in the pancreatic head. And even in the patients undergoing surgery, before Whipple's, almost half are already exhibiting PEI. And of course, that increases once the surgery removes the head of the pancreas. So we could skip to the next slide. So just a little bit of an anatomy lesson for everyone. So we could see the pancreas there right in the middle, sort of a yellowish green color. And you could see sort of what I was talking about, the head versus the tail, that's right back there behind the stomach. And there's a real intricate choreography that takes place when food goes from the stomach into the upper small intestine, where there are triggers to release these enzymes, to release bile. All these are necessary to digest food. And if you skip ahead to the next slide, I'll show you a little bit of what happens in the case of PEI. So on the left, we could see what happens in normal digestion, essentially. So food enters the intestine, the enzymes are released by the pancreas. The enzymes break down fat, proteins, carbohydrates into small bits that are really easily absorbed in the intestine, and food enters the bloodstream, enters the lymphatic system, and we use the nutrients. In the case of exocrine pancreatic insufficiency, as they say here on the slide, there could be a tumor blocking that duct that's near the number 1 on the slide on the right. There could be just the tissues are broken down because of the cancer, and the enzymes are not being produced adequately in sufficient amounts. So the food that we eat sort of remains intact. It's not broken down, as you could see going down the intestine. And that food remaining intact actually leads to a whole bunch of symptoms that are very unpleasant. So you could switch to the next slide. And some of these symptoms include weight loss, gas, bloat, cramps, loose stool, diarrhea. The stool that patients have is described as really foul smelling. It's weirdly colored. It could be yellow, pale, beige, white, or the worst case scenario is that you have an oily film floating on the water in the toilet bowl, which is a real sign of very advanced malabsorption, where the fat that you're eating goes right through your system and comes out into the toilet. Excuse the visualization, but this is what I talk about with my patients all the time. So you could see that having all these symptoms could be very unpleasant. It leads to patients losing weight, being afraid to eat, not leaving the house because they need a bathroom all the time. So very unpleasant, and we could do something to stop this or to reduce it. So why aren't we? So next slide. And it's been very well documented that this is undertreated. So just some recent data from Roy et al. So in the US, only 22% are treated for PEI. And amongst those 22%, which is already atrocious, 90% are not receiving adequate dosing of enzymes to replace what the pancreas is not making. In the UK, they're a little bit better. So the surgical patients are being treated, but for some reason, the patients with advanced disease, metastatic disease, where the tumor is really just going to make the situation worse, we're still under treating. Less than half are getting treated. So we really have a lot of work to increase how many patients are being treated and to educate healthcare providers to be aware of PEI. Next slide. So again, I care about quality of life. So treating PEI helps stop weight loss. It allows patients to tolerate their treatment, and it improves overall survival. And the next speakers will talk a little bit to that. Next slide. So of course, I am a registered dietitian. I consider us the superheroes of PEI and its treatment. We're very well placed to help out the medical team in assuring that our patients are getting enough enzymes to replace. We know that at diagnosis, over 80% of patients with pancreatic cancer have already experienced weight loss. So we want early referrals to our dietitians. And if there are no dietitians in your centers, as advocacy groups, pushing for dietitians in pancreatic cancer centers is really important. So next slide. And you could add on. Okay, so what can a dietitian do? First of all, she or he will look at what you're eating. Are you eating enough? What is the composition of what you're eating? If there is PEI and there is treatment, is it being adequately treated? Are there enough enzymes now? Have we reduced the gas, bloat, diarrhea, oily stool, stinky stool? And if not, we're well placed to see the medical team and say, hey, we need to start pancreatic enzyme replacement therapy, which the next speakers will speak to. And then if there are other symptoms making it difficult to eat, the dietitian will offer tips to reduce nausea, vomiting, lack of appetite, taste changes, smell abnormalities. We help manage those symptoms. And then there's one more point, I believe. And in the case where a patient just cannot eat enough, we'll suggest some supplements, whether they be oral nutritional supplements, vitamin, minerals. We're well placed again to evaluate what's being eaten, to see the side effects of the treatments, to see the side effects of the PEI, are there symptoms, to suggest the enzyme replacement therapy, and to ensure adequacy of nutrient intake overall. And this will lead to better quality of life, maintenance of strength. And if you're maintaining your strength, you're going to receive more treatment. And that's the ultimate goal. So that's it for me. I advocated for my profession, and I'm very happy to take any questions that listeners may have.
I got a couple of questions. I was actually asked by Let's Win in the States. I did a little interview for them, Poppy, and one of the questions was, what's the difference between a dietitian and a nutritionist? It seems to, depending on your province, depending on your state, depending on your country, there's some, in some provinces, there seems to be a common standard for licensing, and then for other provinces, there isn't. And I'm not sure about other countries. Can you speak a little bit to that?
It's very confusing, even for me. In Canada, depending on the province, not all of these titles are protected. So, for example, in Quebec, a registered dietitian or a nutritionist, same thing. We have the same schooling. We're registered with a professional order. It's the same thing. It's not the case in Ontario, for example, where it's just registered dietitian is the profession. So, and in the States, I believe it's even more confusing. So nutritionists could be people who've taken a course on the web. It's very, very confusing. I would ask, if you're consulting someone, if they're registered with some sort of professional order, that might help clarify things and what their schooling was. Is it a university, at least a 3-year university degree with an internship? That would be the way to determine whether someone is really a registered dietitian.
Okay, wonderful, thank you.
Poppy?
Yes, hello.
This is Natalie.
Yeah, when a person does a Whipple, should they go on pancreatic enzymes Is what you're saying? They should go on it?
Yep.
Do all doctors who do Whipple suggest it?
Nope.
That's the thing.
Nope.
No, I'm
that's-
glad to hear that, because I'm actually helping a lady right now who MD Anderson had told her she was not eligible for Whipple, but I got her to see a guy called Dr. Douglas Evans, and she's going to do her Whipple next month. So I want to tell her about this.
Look, a tumor in the pancreas, especially if it's in the head of the pancreas, it's only going to grow, especially in the case, like she is going to get a Whipples, but say eventually, or if it's someone who's not getting the Whipples, it's going to grow, it's going to cause problems.
Right.
Sometimes patients will start on enzymes, and as the disease progresses, they need more. And they're like, well, why do I need more? It's like, because the functioning of your pancreas is just deteriorating. You're having symptoms, So yes, everyone, I believe, who gets a Whipples needs pancreatic enzyme replacement therapy, and there might be adjustments to make to the dose as the disease progresses.
Right. So I was going to also ask you about that. How do you determine the dose initially? Is it based on the person's weight, or how is it determined?
Our next speaker will speak to that. I don't want to steal Dr. Lander's thunder.
All right, no problem.
Anders, do you want to ask your question? Anders is saying he takes so Anders says I take 3 times 5 and 3 times 2 Creon daily, but my D and K vitamin is too low. What can I do to increase Creon? I have no pancreas after cancer operation. So they're speaking to the 25 units.
I guess my question is, are you taking supplements, vitamin supplements? Because I would take them at the same time as Creon, if you're not doing that already.
Okay, so Anders, I don't know if you can unmute yourself and ask or answer Poppy's question. Sometimes people's
now I am there. Okay.
Hi, Anders.
Hello. I don't take any vitamins now, but perhaps I should do that.
You might need to, and you would take them at the same time as the Creon.
Okay.
They're fat-soluble vitamins, so you want to make sure that you absorb them, and you'll need the enzymes.
Okay, very good. I will try. I have lived now 6 years without pancreas, and they told me that I could live only 7 months more, but I still alive, and I found a very skilled doctor who operated me.
Wow,
That's amazing.
Amazing.
Yeah, fantastic. I have a very nice life.
Wonderful.
Yeah.
So if there's no other questions, I do have, Poppy, you said something, I never really thought about it until you just said it, regarding, thinking of PERT also as a baseline, so that, when you first started, it doesn't mean that it's always going to work right away. That it may take some playing around and figuring out the proper dosage, based on your meals and your snacks, and thinking of PERT just like we would in many ways when we're looking at the CA19-9. It's a baseline, and how do we improve your quality of life, and how do you improve patient outcomes using PERT, but using that baseline that you started with, and being flexible to know that it may not work the first time around, that you may have to adjust dosages.
Yes, absolutely.
Well, wonderful. Dr. Kasvis, thank you very much. You're wonderful as always. I'd like to introduce Dr. Amanda Landers. As we said, Dr. Amanda Landers is from Aotearoa. So I'm using my phonemic sounds there. Medical school in Christchurch, New Zealand. And she is, as I said earlier, currently a senior clinical lecturer, and has done extensive research around PERT, and it was a pleasure to meet a few weeks ago, and has a wealth of information. She's been looking at PERT and PEI since 2010, I believe she had indicated to me. So Amanda, Dr. Landers, welcome.
Tēnā koutou katoa, everyone. That's our Māori greeting here in New Zealand. I'm also a palliative care specialist, and so look after people with life-limiting illness, and pancreatic cancer obviously falls into that. And so, yeah, we became interested in pancreatic cancer and enzyme replacement therapy back in 2010. It was actually a dietitian and I that launched this group, and gathered like-minded people across Australasia to look into this further. Next slide. And pancreatic exocrine insufficiency is quite a mouthful, and often loses people when you're trying to talk to them. And I spoke to somebody recently who actually an oncologist who called it pancreatic failure. And when we talk about heart failure or lung failure, people really jump and really worry about and are concerned about those conditions. But when the pancreas fails, we seem to just kind of not worry so much. It's kind of a silent issue. And so putting the word failure after it kind of heightens the awareness that this is an actual problem. And so I quite like that terminology, and I've been using that terminology with my colleagues a little bit more, just to shock them into thinking that this is an organ just like the heart and the lungs and the liver, and so we need to worry about it just as much. And so that's just my little campaign. Next slide. So what is pancreatic enzyme replacement therapy? And Poppy's already alluded to it. And Poppy, you'll be a little bit jealous to know that in New Zealand, dietitians can prescribe PERT. And so dietitians are really leading the way here, and gathering the knowledge and awareness in our allied health community. Next slide. So they're little enzymes. I kind of think of them like the Pac-Man. They're little enzymes that go chomping into food, as Poppy spoke about. And one of the more important points is that they come in different strengths. So please make sure when you're talking to people about PERT that you are aware that the stronger the strength, the kind of better. There's more enzymes, more digestion in the different strengths. And they come as units, and they are pig-based. So just have to be a little bit aware of cultures that do have issues around taking anything that's porcine or pig-based. And the dose is determined by the amount of fat really in the meal. So Poppy talked about the fatty bowel motions. It's the fat that kind of gives a lot of the symptoms. And so we want to break down the fat as much as possible. And what tends to happen is people avoid fat because it causes symptoms when they eat it. And then, of course, they lose weight even more because they're losing their calories. So it becomes a bit of a vicious cycle. And just a little point, if someone has a sulfur allergy, you have to watch the use of Creon. So just a little point there. One of the other really critical things, and something that we see being done quite poorly in our medical community, is the information that people have to have enzyme replacement with meals and with snacks. So there's no point in people being really diligent about taking the enzymes with their breakfast, lunch and dinner, and then having cheese and crackers at night time before bed. It has to be taken with anything pretty much apart from fruit, jelly, fizzy drink and cordials. So they'll be malabsorbing anyway if they're not having it with snacks, and then wondering why this medicine doesn't work. So just an important point to take away from today. Next slide. If people are having a large meal, then they need to have it split through the meal, or they could split it. So remember, it's these kind of enzymes chomping. So you could have it just as you start to eat, not 30 minutes before, like we often hear. Has to be at the time. You could have a little bit more midway, and even right at the end, just to mop up the larger meal. They shouldn't be crushed or chewed because they're little micro beads, and they can be put in blister packs checks. I'm not sure if your countries have them, but it means that they're easily available for people to have, and they can cause people to go from having diarrhea to constipation, so especially if they're on morphine or pain relief. So you just need to have a laxative regime ready in case that happens. Next slide. And I guess one of the other critical points is it's really hard to have too many. You can have many creon a day and you're not going to overdose, which is often what people worry about. So the dietitian I work with here, she actually lets people know what the top dose is so that people feel happy to adjust underneath that, knowing that they're not going to overdose. Next slide. And so you just have to watch what you take with the enzymes. So things like calcium or magnesium for soothing the tummy can make the enzymes ineffective. And if the enzymes are not quite doing the job, you can add a proton pump inhibitor like a miprazole, pantoprazole. You could ask your doctors about that. That just helps the effectiveness. Next slide. So what we found was similar to what Poppy talked about here in New Zealand. We did an audit back in 2012 actually, and found that only 21% of people referred for advanced pancreatic cancer were on enzymes. This was a bit shocking to us, and this is what started our road. Next slide. And we actually found pretty much what Poppy said, over 70% of people not on PERT were having abdominal pain, which is how I got into really being concerned about this, because I didn't want to start morphine for people that should be having enzyme replacement. And so I wanted to know if we were doing best practice for these people, and they get windy and bloaty, and it's a really, difficult way to live. Next slide. So we did a study where we gave them best practice. We gave people with pancreatic cancer best practice, and we did some surveys before and after, and showed a significant result. Next slide. We had 97 patients. It's pretty hard to do studies in people with advanced pancreatic cancer, as you can imagine, but we had really good relationships with our surgeons here and our oncologists, and they referred to us quite promptly. Next slide. And we found, not surprisingly, that diarrhea improved significantly. So did pancreatic pain, which can be quite nasty, and bloating and gas. So we were kind of pleased, even though it wasn't a placebo randomized controlled trial, that we did find some significant results. Next slide. Then we wanted to ask people themselves with pancreatic cancer what it was like to take those enzymes. Was it actually a burden? Did it actually impact their quality of life? And we had the most amazing interviews with people calling them their miracle pills, and the fact that they'd go back and have Kentucky Fried Chicken, which they had been avoiding. So it was quite a game changer for many people that we talked to, and it changed their relationship with food. So that really reassured us that we were on the right track, because we heard it from people themselves. Next slide. And just to let you know, there's very little literature out there. So we really are in a bit of a green field in terms of making changes for this community, who is quite a silent community. Next slide. And we've just completed a national population survey using mixed media in both Australia and New Zealand, where we actually went to the people with pancreatic cancer and asked them about their PERT prescribing and how they were actually taking it, and we'll be putting out those results. But just to let you know, on the second to last slide, I think, next slide, that almost 40% of those people had never heard of PERT in New Zealand, and about 30% in Australia, and it was higher for our Indigenous population, our Māori population. So I've got a real heart for equity for our Indigenous population, and we want to do everything we can to make sure we don't perpetuate inequity, and that includes involving them right at the start with all of our patient documentation, information, and ways that we engage with people with pancreatic cancer. So next slide is the last one, I think. So is it time for an international position statement? And I guess that's over to you guys. I feel like in our countries, or all the countries that I've read information on, the numbers are really low for getting best practice. And I wonder if it's time for us to, to write an international position statement about this and actually put a line in the sand and say this is actually a necessary intervention and should be put at the same level as surgery, chemotherapy and radiotherapy in oncology treatment. I'll just leave it there. There's other slides, but people can read those. Thanks.
Oh, that's wonderful, Dr. Landers. And I'm like, yes. This statement would be fantastic. I'll ask one question and it'll give everyone an opportunity to come off mute if you have a question or to put up your Zoom hand as well. Poppy touched on it, as did you, and it's about that relationship with food, but also about the relationship between the patient and the caregiver. Because a patient not eating, or experiencing all the discomfort that's caused by food when they're not on PERT, causes so much stress just even in the family unit. I remember, my dad not wanting to eat and me trying to get him to eat. And I think now, like, what was I thinking? The food I was trying to blend, and who would want blended food, and he didn't have access to PERT. But it's, there's the relationship to food is so important because it's really what makes us feel okay. And feel okay for treatment and feel okay to, and to have a quality of life. So, this is another reason why, treatment is so imperative, really. And you're right, it should be taken just as seriously and understood that it's just as serious as chemotherapy and surgery. It should be looked upon as equally as important. I don't know if anyone else has any questions for Dr. Landers before we move on. You also made a great point about, it's too hard to have too many. I think people are always nervous, about the over medicating. So that was a fantastic point. When patients aren't able to take the enzymes with the pig enzymes, what do they do?
There are different strengths. Creon has the biggest market share. They're about 85% globally of market share, but there are a couple of other preparations, and there is one. I was actually the sulfur allergy is the one I was thinking of. If it's a person, say, of Jewish faith, they can talk to their rabbi, they can talk to some of their leaders, and often when it's a medical indication like this, they will be kind of given permission. So it's worth letting them know, obviously, and then it's worth encouraging them to talk to their spiritual faith leaders. Yeah. Okay.
I think when you were saying that nutritionists also or dietitians are able to prescribe enzymes, I feel like that's not the way it is in Canada right now, but I do feel like the tides are changing here in Canada as pharmacists are taking on more responsibilities, more medications that they can prescribe. So that's something to consider as an advocacy organization.
I think lobbying for dietitians and allied health to be able to prescribe is actually really important.
Yeah.
We have good links with New Zealand Dietitians Association here.
Yeah, that's a great idea for us, here in Canada.
Just to pipe up, in Canada, we're allowed to, as dietitians, prescribe digestive enzymes just to unblock a tube, but nothing by mouth. So it's a little bit crazy.
Okay. All right, I guess it's time. I'll introduce our final speaker. And once again, this is Dr. Enrique Dominguez Monez. And as I said, he's a professor and director of the Department of Gastroenterology and Hepatology in Spain. And this has also been a passion of Dr. Dominguez Moniz, PEI and PERT. He's done extensive research and really has helped lead our organization, you know, to doing a little bit better than what we were 4 years ago. So Dr. Enrique Dominguez Moniz, welcome.
Thank you very much. It's a real pleasure to be today with you. For me, it's an honor being part of this meeting. As you have said, I have been involved in pancreatic exocrine insufficiency for many years, many more as you can imagine, more than 30 years, and we publish a lot of papers on this field. May I have the next slide, please? This is just to show you my hospital, and then the next one. And yes, this is just to tell you that we are still very actively developing projects in pancreatic exocrine insufficiency. I'm leading now the European guideline on the diagnosis and therapy of pancreatic exocrine insufficiency, together with all the societies that have something to say about PI at the European level, including surgeons, including oncologists. So that will be a very nice interdisciplinary guideline. I'm coordinating the European PEI registry, which I'm sure it will provide us with really important information about the optimal therapy of PI in different clinical conditions. And I can announce you as well that we are in the way to start already the so-called PERT-7 trial. So we have designed a new study on PERT in patients with unresectable pancreatic cancer. Next, just to show you that we are still very active on this field. Look, this is a very important slide because, I mean, you are too young and probably you don't know the development of the concept of pancreatic exocrine insufficiency, but this is a real change in the understanding of PI. And today, when we talk about pancreatic exocrine insufficiency, we are talking about malabsorption of nutrients, maldigestion, malabsorption of nutrients, and therefore maldigestion-related symptoms and nutritional deficiencies. That's the main reason of this topic. Next slide, please. Next, please. And you have heard already about the consequences, but there are a lot of studies evaluating the consequence of PI, many of them very recent studies, showing that symptoms of malabsorption like diarrhea, weight loss, flatulence, bloating, abdominal distension, abdominal cramps, and so on, leads to a poor quality of life in patients with PI, and the nutritional deficiencies, which is a quite complex profile with different nutritional deficiencies, are associated with an increased risk of weight loss, sarcopenia, which is a very important nutritional marker, surgical complications, poor tolerance to chemotherapy, and a short survival. So we are talking about really relevant today. Next, please. And I would like to tell you something important. There are two main clinical scenarios when we talk about pancreatic exocrine insufficiency in pancreatic cancer. One are the patients with a tumor in situ. That means before surgery, or those patients with non-resectable tumor. And a different scenario are the patients after surgery. Next slide. And that's important because if the tumor is there, is not yet operated on, or is non-resectable, look, important is, as you heard before, is the location of the tumor. If the tumor is located in the body of the pancreas, as you can see in the slide, the head is free. The head can synthesize and secrete enzymes. And these patients do not always develop pancreatic exocrine insufficiency. However, the closer the tumor is located to the duodenum, to the gut, the less pancreatic parenchyma is remaining, and the majority of these patients, I could almost say everyone, develop pancreatic exocrine insufficiency. So the location of the tumor is very important, and that explains why not every patient with pancreatic cancer develop pancreatic exocrine insufficiency. Next, please. And the second scenario is surgery. You have there a picture of a surgical procedure, a Whipple procedure, and after surgery, everything is disturbed. Physiology changed completely, and after this kind of surgery, it is impossible to digest food normally and to absorb nutrients. Next, please. The two main issues here is that these patients produce a very low amount of pancreatic enzymes due to all the physiological changes and the pancreatic resection as well. And the enzymes cannot mix properly with the nutrients to be digested and absorbed. And that explains why these patients develop PI almost consistently. Next, please. Look, what is our practical approach? How can I help you to tell you, do you have PI, yes or not? If the tumor is located in the head of the pancreas or after surgery, we don't need to make any diagnosis. That is already a clear indication of therapy because PI is always there. However, if the tumor is located in the body or tail of the pancreas, or the surgical procedure has only resected the tail of the pancreas, body tail of the pancreas, we need to make the diagnosis of PI before prescribing the therapy. And the diagnosis is based on symptoms, nutritional markers, and pancreatic function test. Next, please. So you said before that there are different enzyme preparations. The enzyme preparations are made in a way that you know that they are pellets, and these pellets should disperse in the stomach in order to mix with the nutrients, with the food in the stomach. That is absolutely critical. Otherwise, the preparation cannot be effective. Each one of these pellets is coated in a way that the enzymes are protected against the acid-mediated inactivation. They should be emptied from the stomach together with the meal, not before, not after. The pH in the gut should be normal. And once the pH is normal, the enteric coating should dissolve rapidly in order to release the enzymes. And this is very difficult to achieve. Not all the enzyme preparations are by far the same. The only thing that we can do is modify the pH in the duodenum and prescribe an adequate enzyme dose to achieve an appropriate therapy efficacy. Next, please. So what is the dose? You were talking about that before. Look, this is the dose, the minimum dose to start with. At least 75,000 units with each meal, main meal, at least 50,000 units with each small meal or snack. And you forgot something important today. Always, in patients with pancreatic cancer, always we need to inhibit gastric acid secretion in order to make the enzyme therapy effective, because these patients do not secrete bicarbonate, pancreatic bicarbonate, and therefore the pH in the gut is acidic. And at that pH, the enzymes from prion, for example, cannot be released, or they are released very distally. If that is not enough, increase the dose. Increase the dose as much as you need to relieve symptoms and to normalize the nutritional status. Next. So what can we expect from the therapy? We have a lot of studies showing that we can improve digestion and absorption of nutrients. We can relieve maldigestion related symptoms, weight gain, improve nutritional status, better quality of life, and longer survival. This is a lot what we can achieve with this therapy. Next slide, please. And this is just to show you our study in patients who had a significant weight loss before the diagnosis of the disease. And you can see the huge difference and highly significant difference in survival of patients who were on pancreatic enzyme replacement therapy compared to those who were not taking pancreatic enzymes. So we are talking about an improvement, a clear improvement in survival. Next slide. And there were only one factor in that study associated with a shorter survival, and that was metastasis. And only 2 factors associated with a longer survival. These were patients with non-resectable pancreatic cancer. And these 2 factors were chemotherapy and pancreatic enzyme replacement therapy. Next. And this is almost my final slide, just to show you, look, everything that is on the right of this vertical dotted line, about the 1 point, means that these factors increase survival in patients with pancreatic cancer. And these factors are only 3: surgery, resection of the tumor, chemotherapy, and pancreatic enzyme replacement therapy. And you can see that the impact of these therapies on survival is very similar. The impact of pancreatic enzyme replacement therapy is very similar. Look, very shortly, what are we doing? We knew from decades ago that pancreatic cancer causes weight loss, cachexia, malnutrition, and this is associated with a limited tolerance to chemotherapy, poor quality of life, and a short survival. Next. What we know today, next please, is that PEI plays a major role here. And next, and therefore, when we prescribe enzymes, what we are doing is avoiding the impact of PEI on the clinical picture of pancreatic cancer. And next, this is just the, next please, this is just the summary. What I wanted to tell you is that PEI is a frequent complication of pancreatic cancer and pancreatic surgery. It's associated with symptoms, nutritional deficiencies, and weight loss, leading to poor quality of life, poor tolerance and response to tumor treatment, complications, and short survival. The development of PEI is the rule in patients with the tumor obstructing the main pancreatic duct in the head of the pancreas, as well as in patients after pancreatic duodenectomy, Whipple operation. And in other scenarios, diagnosis of PEI requires evaluation of symptoms, nutritional status, and tests like fecal elastase. Next, and this is the very last, treatment of PEI is based on nutritional support and oral pancreatic enzymes that should be taken along with meals and snacks. A proton pump inhibitor, omeprazole, pantoprazole, the one you like, is needed associated with PERT to ensure the release of pancreatic enzymes in the proximal gut. Pancreatic enzyme replacement therapy leads to symptom relief, improved nutritional status, weight gain, improved quality of life, better tolerance to tumor therapy, and increased survival. The initial dose, we talked about it before, and if this dose is not enough, increase the dose as much as you need in order to achieve weight gain and improve nutritional status. And the very last, next slide, please. Please, next, are some pictures from Santiago de Compostela. I hope to have the chance to welcome you in my city. I don't know, sometime, who knows? Thank you very much.
Thank you so much, Dr. Dominguez Moniz. That was amazing. There's a couple of questions in the chat box, so I will start with, so we have Anders. He asks, how do I know if I have the right pH?
As far as I can remember, Anders was the person after total pancreatectomy?
Yes, yes.
Okay, I tell you, your pH is acidic. You don't have any pancreas. The pancreas is the one producing bicarbonate to neutralize the acid, the gastric acid. Therefore, it is absolutely mandatory to take omeprazole before breakfast, before dinner, in order to make the enzyme therapy effective. Otherwise, it cannot be effective.
Omeprazole. Okay.
For example, before breakfast, before dinner.
Okay, thank you.
And Susan, did you want me to ask your question, or do you want to ask? I always like to get people involved. Put them on the spot.
Hello. That's okay. Hello, Dr.
Here you go,
Dominguez.
Susan.
Yes. I just wanted to ask, does a dosing based on fat intake per meal make sense for a pancreatic cancer patient? Because this is done for cystic fibrosis, for example, the dosing depends on the fat intake. Would that make sense for a pancreatic cancer patient, or do we just initiate 75,000 lipase units per meal right away?
Well, there are two important points here. First of all, to talk about 75,000 units is just a general guidance, if you like, but this dose is quite low. Actually, I never prescribe that dose to my patient with pancreatic cancer. I start by giving higher doses because I don't want to lose time with them. So to recover the nutritional status. And I mean, we always talk about fat, but we are not just digesting fat with Creon. We are digesting proteins, which is much more important in patients with pancreatic cancer, and carbohydrates. So important is to guide the dose of enzymes according to the food volume, caloric content, fat content, and so on. And the amount of enzymes depends on what the patients eat, obviously, because I always say to my patients, look, the enzyme is not for you, it's for your meal to be digested. The enzymes will not be absorbed. It is not for you. It is to digest the food. So the way I do it is to ask to my patient, what is the main meal? It can be lunch, it can be dinner, depending on the patient. And in that meal, I prescribe the full dose that I want to prescribe. And frequently, I start by giving 100,000 units in that meal. And then I ask him, how is, for example, if the main meal is lunch, I ask him, how is dinner? Is similar? Is a bit smaller? If similar, I prescribe the same dose for dinner. If smaller, I prescribe 1 capsule less. Exactly the same with breakfast and snacks in between. So at the end, it is true that the dose should be guided according to the food intake, not only to the fat intake, but to the food intake.
Thank you, doctor.
We also have a question from Catherine Min. Catherine, did you want to ask your question?
Yeah, yes, I did.
Yeah.
Yeah, that's my question. I just chatted on the chat room. So that's my
Yeah.
question. Does
So-
it really, yeah,
Yeah, so,
PERT,
sorry,
yeah.
do you want to ask it just to Dr. Dominguez Moniz?
So your question is about treatment after surgery, doesn't it?
Yeah. Mhm.
Okay, we are talking about Whipple operation, about duodenopancreatectomy, not about distal pancreatectomy. After Whipple operation, the pancreatic enzyme replacement therapy is mandatory. I don't care about symptoms. You know why? Because it's very easy to avoid symptoms. The only thing that you should do is eat nothing. If you reduce the fat intake, if you reduce the amount of food that you eat, you will not develop symptoms because you have a certain capacity to digest food, but you will develop malnutrition. And the issue here are not the symptoms. The issue here is malnutrition, are the nutritional deficiencies. Therefore, we don't lose one single day. The first day that the patient start to eat after Whipple operation, the patient is taking from the very beginning pancreatic enzymes orally. So there is no doubt about it.
Wonderful. And I think we've gotten everyone's questions. I had one
No, I
question.
have a question to Stephanie.
Oh, yeah, go ahead, Natalie.
Doctor, so how long after doing Whipple, if a person has disease-free survival after 5 years, do they keep taking pancreatic enzymes for the rest of their life?
Yeah, look, I always like to compare pancreatic exocrine insufficiency with diabetes. Once you need insulin, it's forever. Once you, I mean, after the anatomical change, after surgery, physiology will never be the same. So digestion will never become normal again. So that is forever. That is lifelong.
But there's one other question I have. Pancreatic enzymes are very expensive. So how do people continue on with that regime? You know, taking 75,000 or 100,000 per meal, it's a lot. And I think this is what makes it kind of difficult. Is there a generic or another brand that's
No.
more affordable?
No, and I'm not sure about the generic in that field because developing or producing pancreatic enzyme preparation is very difficult. So I will not trust so easy generic in that field. I mean, this is a different problem. And of course, that this is a problem in real life. I'm talking about the need of pancreatic enzymes in order to keep a normal nutritional status in patients with pancreatic cancer or after surgery, which is absolutely critical for the prognosis of the disease. Like any other medication, if the patient cannot afford it, then this is a different problem, a social problem, economical problem. But the medical need is there. And for example, in Spain, pancreatic enzymes are free for the patients, fully free. It's fully reimbursed independently of the indication. And that makes things, of course, much easier. But this is something probably that we need to fight to get it because this is a chronic medication that is absolutely needed for the survival of the patients, for the prognosis of the disease.
Well, and that goes back to Dr. Landers, you know, her last slide about the importance of maybe a position statement, you know, and it just makes sense when you described it. You said something that kind of made me smile because you said, it's impossible to change your digestive system and not have an impact from it from having a Whipple surgery.
Yep.
And when you put it that way, it just makes sense, that we do need to, we do need to make sure that everyone understands the impact that a surgery like the Whipple is, but also that you do need follow-up support after your digestive tract has been changed. In interest of time, I think what I'll do is introduce myself for the last bit of the presentation. We started 5 minutes late, so I'm actually going to cut this down a little bit and let the participants explore it a little bit on their own as well. But after speaking with Dr. Casvis and Dr. Dominguez Moniz, and certainly seeing all the work of Dr. Landers, and hearing from our patients and caregivers for quite some time, we did know after, and also initiating a Canadian-wide survey amongst patients and caregivers, we certainly learned that there's a huge deficit in understanding what pancreatic enzyme replacement therapy is, how to, what it is, how to use it effectively. We also know that about only 20% of the population that should be getting it is getting it. As we saw the other numbers, in our numbers, only half of that population is even getting the correct dosage. It looks like, based on Dr. Landers' research, even less than that. So Craig's Cause Pancreatic Cancer Society and the Canadian Digestive Health Foundation partnered to create what we believe is the first PERT calculator. And we also had it Health Canada approved. So we do have a licensing for this and approved by Health Canada. So this calculator essentially will tell patients after they input their meals how many capsules they should be taking. So Craig, I don't know if I haven't seen the other slides, should have, my apologies. So the calculator starts with just some general information, some metrics that we're collecting. First to make the correct dosage, to get the correct dosage, but also, we want to know who's being impacted, what diseases they have. So we're asking for weight. Craig, so it'll take in it's asking for the patient's name, contact information in case there was a recall, or if we had to get a hold of them. It also will take in the diagnosis that they have and really where they're from. And then Craig, is there a screen there with the food? Yeah, so the patient would be then, once they register for this, they register it for it once. Once they register for the app, they'll be sent an email and they can go right into the calculator and they can put in the food that's in their meal or with their snack. So Craig, I don't know if you can go to the next slide, but it's a scroll down screen. So it takes you through your protein, your soup, sauces, your vegetables, your breads, and everything else. So everything that's a part of your meal, you'd input into this calculator. And then it's going to give you your total lipase units needed for the meal that you described. And it will also tell you the recommended number. Part of the registration, you can also put in what your Craig's circling around. He's saying, select which PERT you have been prescribed. Thank you, Craig. So part of the registration process is putting in whether you're taking Creon or a different PERT that you've been prescribed. Once again, you put in your meal and it should calculate, or it will, not should, it will calculate how many lipase units that you'll be taking. At the end, once it shows you your meal, it'll give you a breakdown of what you put into the calculator. You can also start a new meal. You can send us information about what foods you would like to recommend that's not on the calculator, that should be on the calculator. And also you can hit on PERT tips, and that will provide you with information that will help not only just with the replacement therapy, but also meal sizes, you know, maybe smaller meals, more frequent meals. It also gives you resources that you can use. There's a lot of great videos out there. And if there's ever any issues, you can also click and send us any information that you need. We were excited. We partnered, Viatris was a sponsor to this, so we're very appreciative of the support that Viatris offered and working with us through this. And our very own Craig and Mia were our geniuses behind this. When I first brought this to Craig, I had to check the pinwheel that you turn on cardboard. And the question was asked, well, how would we get it out to everybody? So that was my, that's how this whole thing started. And Craig said, well, perhaps we should do something online that wouldn't involve mailing out thousands of wheels. So that goes back to my olden days. So as I said, Viatris was wonderful support. We're really excited. We're on to a PERT Calculator 2.0. We've gone through some revisions. We think we have it down to a science now. And as Craig will be able to speak about it, this is health approved in Canada, and it's based on Canadian food and Canadian prescribing. We know that food changes with different cultures, different countries, and as well maybe access to the different replacement therapies that you may be prescribed. So we're maybe Craig can speak to this a little bit, but this is something that we hope that will be able to be accessed in other countries, and Craig can tell you a little bit more about that.
Yes, thank you, Stephanie, and thanks again to everybody who spoke earlier. Essentially, this calculator was made basically from a North American diet, and it's in English and as well as French. And so, as Stephanie mentioned, once you register, you get a link, and then you go through and add what your meal is. And there's proteins and soups and sauces, and it's just one big long scrolling screen. You just click what you're having. It also gives you portion sizes, and if you're, for example, if you pick chicken, it'll give you a drop-down menu: dark meat chicken, light meat chicken, fried chicken, baked chicken, etc. So you can really get specific. All of the information was provided via POPI through the Canadian Dietary Code. I don't know exactly what it's called, but it was a very specific code with fat content and etc. And so it was just a massive math calculation problem. So now the question comes up when we're talking to a global audience is, you know, if somebody in Sweden, for example, wants a program like this, their diet choices are going to probably be a little bit different than a North American diet. A lot of it may be similar. Anybody in the world can go to DigestThis.ca and download and use the app in English or in French with those dietary items. So it probably serves quite a few people in the world just the way it is. But if anybody would ever be interested in a customized version for their territory, with their food choices, with their cultural change, and in their language, that's something that we can talk about.
Wonderful. So thanks a lot, Greg, for that. And once again, we want to thank our sponsors, AstraZeneca, Ipsen, Merck, Novartis, and Novacure. If you do, I know in the interest of time, Mia's giving me the breakdown of time. So in the interest of time, if you have questions and would like to talk to us, I did put DigestThis into the chat. So if you have questions about the calculator and want to set up a Zoom call, please reach out, and I'd love to talk to you more about the online calculator, the PERT calculator. We're really excited. We've gotten amazing feedback. Within a week, we had, and really very little advertising. We had a lot of patients and caregivers, over 130, using this. So we're quite excited with everyone's responses, and certainly the physicians and caregivers are excited as well.
There's also a link
Doctor,
in the survey. Sorry to interrupt, but there's a link in the survey for just a feedback, quick 2 to 3 minute feedback survey. If you look in the chat, just give us your feedback on that would be great.
Yeah, so Dr. Dominguez-Nunes, Dr. Landers, and Dr. DigestThis, again, we are so excited to have had you talk about a really, really important topic. So I'd like to thank all of you. Once again, thanking our sponsors, and I know that we've got a couple of individuals here from Viatris, so I'd like to thank them once again. This will be recorded. It is recorded and edited, and Craig will be sending that out to everybody in the next few days. So you can watch this again. You can share it with your patients and caregivers and healthcare providers that you work with. So I'd like to thank everybody. I hope you learned something today. Take care.